Patrick, are you ready to get started?
I am, but I thought the people doing the starting, so to speak, are going to be Wes and Diane. So
yes, Diane, are you ready to get started?
Wes, are you there? Diane, Wes, are you two there?
Sorry, I unmuted myself on the wrong place. So this is Diane, and bear with me, my throat is pretty groggy today, and I cough so I'm hoping to get through this. Unless Wes gets on, he can go ahead and take over for me. But
well,
the first thing.
Go ahead.
Yeah, go ahead. The first speaker that we're going to hear from is Dr. Kira Minish. I don't know how to say her last name. That's terrible of me. But she is going to talk about the behavioral health impacts because of COVID, and she's from the Department of Health. So we'll go ahead and let her get started.
Good morning, everybody. So I'm not sure who was it that has the slides, but I was told, nope, that's not them. There we go. Okay, hi. My name is Kira Mosath. I'm a clinical psychologist, and I'm one of the leads of the behavioral health strike team for the DOH. And I'm here to talk to you this morning about what's going on sort of on a statewide behavioral health level with regard to this disaster. And we're looking at it from a lens of disaster behavioral health for sure. So I can see the chat, and that's super helpful. So if there are any questions as I go along, please feel free to address them as we go. If there's something that I'm talking about that you'd like a little bit more clarification on, and we'll just go ahead and jump right in then. So, all right. This is a chart that we're using to sort of define and describe the normal sort of typical human response to disasters in general. And it's based on data that was collected from research studies, anecdotal accounts, and personal experiences from disasters for the last 30 years, including 9/11, Hurricane Katrina, anything big, like the tsunami in Southeast Asia, the earthquake in Haiti, and a variety of like other floods and tornadoes and that kind of thing. So we know with some fairly, reasonable statistics backing it up, the pattern with which humans respond to disasters. So for COVID as a natural disaster, we're looking at what that pattern, is how it's unfolding, and then what we can do about it from a professional sort of resource and prep standpoint, and how it's affecting us as providers, as well as, our ability to do our work. So for Washington State, the impact from the COVID disaster occurred in approximately mid-March of 2020. The heroic and the honeymoon phase, which is when optimism is at its highest and the sense of community cohesion, like we got this, reflected in memes and social media a lot, that was approximately late April to early May. Everybody was sort of still shocked about what we were living through, but that was when things were feeling pretty good. And then over the summer, it's kind of gone, it's not quite been this, off a cliff as the graph makes it. It's been up and down, but it's headed in that direction in terms of overall symptoms across not only Washington State, but across the country as well. And what we know heading into the fall months is that the most difficult time for people post-disaster of any kind is typically what's called the disillusionment phase. And the time frame for that is 6 to 9 months post-impact. That's when it's just the hardest for people. People really struggle. And there's a little bit of a challenge, specifically in Washington and some of the northern latitude states, about what else is happening at that same time of year. So the disillusionment phase in a disaster perspective is, like I said, 6 to 9 months post-impact. So for Washington, that's September, October, November, maybe even into December. These aren't hard and fast lines. They're sort of general areas. And what else do we have going on? We've got seasonal affective conditions. We've got daylight savings. And clinically, we know that people struggle with those things anyway at this time of year. And then you couple that with the disillusionment phase, and you have the election, which is a really hot spot in terms of behavioral health for a lot of folks. And then you have the potential for a second wave of illness, right? So all of that combining into the disillusionment phase, which is when people really are, I guess the way I want to define that is that that's when people struggle the most with coming to terms with what we've been through and accepting what the new normal is going to look like. There is still this sort of way of thinking about COVID for a lot of folks where it's like, well, when it goes back to the way it was, right? And that's really, that doesn't happen after a disaster. It can go back to some kind of a way, or it can get better. It doesn't have to be bad, but it doesn't go back to the way that it was, because the context of a disaster sort of irrevocably changes how we interact and how we function. So it can be fine, but that delusionment is really about the coming to terms with mentally. And, you know, people don't like change. We like it to be the way that it was in a known entity. So that's what's going on. And it makes the fall months particularly challenging for those of us who are working in clinical behavioral health stuff. Next slide, please. Okay, so takeaways from our forecast. We've been doing a monthly update to our forecast that probably some of you are aware of, but we've been putting that out since April. And we're looking at about 3 million people, ish, right? And we're tracking this with a lot of good data points, are going to experience clinically significant symptoms. And I would say that number is about 3 to 4 months. So it's between now and the end of 2020 is what we're anticipating. Depression and anxiety are going to be the most likely. I don't know where the slides went. So I'll just keep going, I guess. I don't know where the slides are. So we're looking at depression and anxiety being the strongest or the most likely, and then acute stress. Unlike something like 9/11 where infrastructure is affected, PTSD is not the most common experience for COVID, unless you're talking about people who are in a post-critical care or post-vent situation. Because in terms of direct exposure to threat of illness or death from COVID, it's not as high. So, yeah, I don't know what's going on, sorry.
Paul, someone keeps trying to take the screen from me. So just a second, I'm sorry about that.
Okay, we will carry on. So another thing that's probably not a surprise to any of you is that substance use generally increases post-disaster and post-impact, and certainly for Washington and across the country, that has not been, that's not unique here. So there's a lot of comorbidity with substance use challenges, and heading into the fall and the winter months when people tend to crave carbohydrates more and the holidays, and there's just generally more substance use, particularly alcohol, in the fall and winter months anyway. And what we're seeing with COVID is that what is a little bit interesting is that these are not, for the people who are developing sort of clinical level issues with it, it's not new incident disorders. It's people that have a pre-existing sort of tendency towards a substance use issue that are using more than they otherwise would. So they're not particularly new incident disorders. And then we have those numbers from May. I was just looking yesterday at updated data from cannabis and liquor state revenue, and it's fluctuated dramatically. So we're looking at a big picture from March all the way through the end of August 2020, and it's fluctuated for alcohol particularly from within 4% of normal compared with 2019 to 80% higher in July for sales. So it's kind of all over the map with substance use. But what it is suggesting is that people are using substances as a coping mechanism for this, which again, not unusual post-disaster for sure. Next slide, please. Okay, we know that domestic violence, intimate partner violence, and child abuse always tends to increase post-disaster regardless of the kind, and this is true for COVID as well, unfortunately. So we're seeing a pretty significant increase. The numbers for July and August were a little bit lower. We're looking at about an 8% increase, but we're only also able to access about a third of reporting agencies for law enforcement across the state. So we suspect that the true number is higher than what we're actually being able to see in the reports, but it is still significantly higher than it was in 2019 for all of the months from March through the end of August during COVID. And back to the sort of a summary of those phases again, the peak of behavioral health concerns and challenges for people is really in that 6 to 9 months post-outbreak. We're going to focus on resilience. I really want to emphasize what we can do about it. I'm a clinician and a pragmatist and not a philosopher, so I really want to emphasize like what we can do about these things and what we're noticing in ourselves as providers too. Next slide, please. Okay, so this is sort of the summary of what I was mentioning earlier. This is the combination, the ingredients of the challenging conditions for the fourth quarter. The thing I didn't mention previously is that if there is a large second wave of infections, which could occur relative to the flu season, and people just spending more time indoors as the weather worsens in generally, is that if we have additional lockdowns, restrictions, and there's economic sort of shutdowns as a result of a big second wave of infections, that really has a strong influence on behavioral health because of the lack of financial resources around the same time as the holidays. So not only might people not be able to see friends and family members, particularly elderly family members who might have a health condition or be in a higher risk group, but that we might not have the spending resources in terms of the holidays that we normally would want to have, and that's going to affect people too. So it's not so, there's a lot of challenges for fall for sure, but again, we'll focus on the resilience piece moving forward. Next slide, please. Okay. So a little bit of information, which is probably, again, not new to any of you, but I think it's worth sort of summarizing for you to be able to share with others. What's going on, or part of what's going on right now from a neurological perspective in the context of a disaster, is that the prefrontal cortex is not functioning and communicating with the rest of the brain in the way that it is used to doing. And the reason for that is sort of twofold. Number one is too much cortisol. So we've been into this COVID thing for 6 months, and our brains are tired. And they're very stressed out, particularly those of us who are dealing with childcare at home, trying to school kids and work at the same time. It's a variety of different demands that are really causing stress on the brain. And it would be happening at the 6-month mark in a disaster anyway, right? So the prefrontal cortex is not engaging the way that it normally would be. And the effect of that is that people are having trouble concentrating, they're having trouble, and I shouldn't say people, I should say all of us, trouble remembering things. Like, I don't know about you all, but I regularly lose track of what day of the week it is, regularly. And part of that has to do with how our memories are being affected by being in one physical location for longer than we're used to. Trouble tracking, trouble staying on task, trouble focusing, all of that detailed management stuff. And that doesn't feel good because it feels like performance-wise, we are compromised a little bit. But the other effect that happens when the prefrontal cortex isn't as engaged because of too much stress and adrenaline is that the limbic system is more influential over our behavior than it otherwise would be. And the results of that, I'm sure, are apparent to you in your interactions with your family members and your colleagues, and even just at the grocery store or the gas station. People are just a little bit more quick to anger than usual. They're just, a little bit more keyed up, a little bit more quick to start an argument, and they're just more apt, all of us are more apt right now to respond emotionally than we otherwise would be. And this is normal, right? This is a normal part of the neurological process of having lived through a disaster for the last 6 months. So having that information does two things. Number one, it can normalize the experience for people, right? It's like, oh, it's not just me. I'm not crazy. I'm not alone in this. Like, we are all neurologically kind of in the same position in our experience. And then number two, once you have that realization about like how your brain and body is being affected by this stuff, you can go about, addressing it. But if it's just sort of happening behind the scenes and you're not aware, it makes it more difficult to do some kind of an active or helpful intervention. Okay, next slide, please. Okay, so this is the checklist. I refer to it jokingly as my daily checklist stuff. I don't know if it resonates with any of you, but being distracted, trouble remembering, quick to anger, stomach aches and headaches. In disaster psychology, that's called the MUPS, that's medically unexplained physical symptoms, and it is the reason why disaster clinics run out of Tylenol and Pepcid AC within the first couple of days, always. Because people show up with a lot of somatic complaints that are related to cortisol and anxiety and stress, and it's manifested in a physical way. So very, very normal. Trouble with sleep hygiene, falling asleep or staying asleep, not waking up with your brain busy. The carb craving, it's really helpful to get information out there to people about why we're all craving carbohydrates right now. And the bottom line with that is that carbohydrates are a precursor to serotonin. They create a precursor to serotonin. And subconsciously, at least, we all are wanting that serotonin to feel to make us feel more comfortable, more, warm and cozy. I refer to it as the cozy blanket neurotransmitter, right? It's the one that makes you feel sort of safe and comfortable and at ease. And so no wonder everybody's sort of craving carbohydrates right now, and have been, right, throughout the last 6 months. The joke about the quarantine 15, and I refer to it as getting a tan from the light in my refrigerator, that kind of thing. It's a very real phenomenon for all of us. And then feeling disconnected, even with the meetings, right? We're losing that ability to sort of connect on a personal level because it's a lot of virtual talk, and it eschews the opportunity for that water cooler discussion, sort of checking in with people. I'll say more about that in a minute too. Next slide, please. Okay, so the way that this looks in the workplace, and it's probably going to be, all of us are going to recognize some of these pieces. There's just the more potential for more emotional responding and less higher level thinking because of what's going on with those brain functions. And then when people aren't able to process emotional rewards that are positive, burnout is likely. So another thing that happens as a result of the prefrontal cortex disengaging a little bit is that our brains, when we're stressed, they're not attending to positive input. It's not important when you're under stress, because what we are tuned into right now are things that are threatening. So we're constantly sort of subconsciously scanning our environment for threats because we want to protect ourselves from the stress that we're undergoing. And as a result of that, one of the things that goes by the wayside is the ability to really attend to and let positive feedback and positive information sink in, which definitely contributes to burnout, particularly in a long-term response like what we're in. So part of this work is recognizing our need to tune into the compassion rewards, to the things that reward us for our work, and recognize that our brain doesn't do that naturally right now. Those things aren't considered quote unquote important to us to keep us alive and surviving, so we don't notice them as much. Next slide, please. Okay, so findings for medical providers in general. This is based on data from China and Italy. And it's looking at, very, very significant rates, which is normal for disasters, but healthcare providers are particularly badly affected. So 70% of people reporting psychological distress, and a variety across the spectrum, right, in terms of anxiety, insomnia, whatnot. And this is something that we really need to work on, not only stabilizing, but getting people prepared in terms of whatever is to come with fall. And being as resilient as possible with a plan in place for what's going to happen in the fall months. And I can talk more about some specific ways to do that with the training that we have at the end of the presentation. Next slide, please. Okay, responder families. So there's some data about what's going on with kids, and that kids are a probably overlooked and more at-risk population than we tend to consider. And children of frontline healthcare workers are at particularly higher risk for emotional impact because of the stress that their parents are experiencing. So these families are ones where they might have even more sort of social isolation because of the physical risks that their parents are exposed to, and there's a trickle-down effect for that. I'm only adding this here because I think it's important not to overlook, the family component of a social support for a healthcare worker might be even more compromised because of the nature of COVID as a disaster. It's going to affect healthcare workers in a much different way than it affects other kinds of responders, for sure. Next slide, please. Okay, so other impacts on kids. And we do have a family toolkit that our team has developed and is available publicly that I highly recommend as a resource. The link is there in the bottom of the slide, Family Toolbox. It talks about these known patterns of disaster responses for kids, like what are you likely to see, and then also what we can do about it, right? So how to recognize it, and then what are the tools that are helpful in kids regulating emotional responses and mastering their fear around these kinds of things. So one of the takeaways I think from this that I would stress for you all is that parents working on and figuring out how to do their own emotional regulation and modeling that process for kids, even if it's not super great all the time, or even if it's really difficult, just the modeling of that process can really be helpful for kids. They see you working on it, then they're going to work on it too. So yeah, I just encourage people to sort of recognize the trickle-down value effect of working on your own emotional regulation in this context. Next slide, please. Okay. Behavioral health providers. We are actually in the middle of doing some research, like data research on this particular thing, but we don't have any statistics to point to from studies that have been done thus far, and that's why we're working on it. So COVID definitely does impact behavioral health providers, but the evidence is anecdotal so far. So we know that people are struggling with more acuity. There has been a surge in patients, and then just overall fatigue, like compassion fatigue and burnout. Stress related to the move up to telepsychology. I don't know about you all, but I get really tired of staring at a screen for so many hours per day and just physically not moving around as much. And then that loss of personal contact, that loss of those sort of just water cooler, just chatting, seeing how things are going. I was sitting in the meeting at the beginning, and there were two folks who hadn't connected with each other in a while, and they started just to have a chat. And then in the context of recognizing there were 40 of us on the call already, sort of tabled their discussion until later, but they were just reconnecting. And that's the kind of thing that if we were all in an actual conference room together, you can continue those private conversations. You can continue those check-ins and those, hey, it's been a while since I've seen you, and those really important connections that we all need right now to support our resilience. But in the virtual meeting context, it's not facilitated, right? We don't really have those opportunities to do that. And that can have an effect too. So I'm kind of jumping ahead of myself, but what I would recommend that people consider is that when you do any kind of a big meeting, maybe not with the number of folks that are in this one, but for meetings that are regularly held with staff that are, in the below 30 mark, that you work on including a time in the meeting where people have that check-in ability. And the way we're doing it with our behavioral health group at DOH is to do a question of the day. And I mean, they're kind of silly, but I've learned more about my colleagues on a personal level in the last couple of weeks that we've been doing this than I did in the months previous because of the response. And the question of the day is something like, if you could listen to only one band or one album for the rest of your life, what would it be and why? And so you do your report, you provide your report, and then you answer the question of the day, and people chat about it a little bit, and then you end your report and it moves on to the next person. So it's a way for us as behavioral health providers to sort of reconnect on a personal level and build that into our meetings so that that piece doesn't get lost. Next slide, please. Okay. Compassion fatigue and burnout. The only thing I'll mention here is that part that's in bold. So nobody is immune from this. All of our brains are in the same kind of position in the disaster recovery and response cycle, and nobody is totally, immune from the processes of these, and that's why focusing on resilience is important for everybody. Next slide, please. Okay, so research is very clear about this. I've been asked a lot when I do these presentations, like, what is the single most important takeaway from this? And there are kind of two. Number one is the psychoed piece about the brain and how we're all affected, because that really normalizes things for people. So that's number one. And number two is this one right here. There is so much research about self-care and wellness, and when we throw around all these buzzwords, right? But what really matters is people walking the walk, that showing and modeling that this is important. Yesterday, I got an email from somebody at DOH, and they had a PS line in their signature that said, it said something like, I may be sending this email at an odd hour, but I recognize that those are just the hours I work, and I don't expect a reply or a response from you during these hours as well. I thought that was awesome. And it really is a good way to model like the expectation around boundaries for work hours. Sending an email at 10:45 at night on a Saturday does not make sense unless you're actually on duty at that time. So walking that walk and showing people how to do this is one of the most effective ways for teams in general to avoid burnout. And like I said, lots of research based on large scale disasters all over the world for how effective this is. Two other things. One that came out of China, which is that if you don't know, let your staff know that you don't know. It's better to be honest about not having the information than to sort of go down a rabbit hole or a trail following something that you don't have all the information about or you're unclear on, and then having to backtrack in terms of what that does for staff, mental health wise. There's just a sense of trust that's eroded. So being honest about not knowing is important. And then active listening, I'm sure is something that y'all are familiar with, but it gets lost in response because it's not problem solving oriented. And there are so many problems right now that the irony is that active listening is actually one of the most effective ways to help people feel better, because it's not problem solving oriented. You can't, right? The problems are so big that you actually can't solve them. and active listening that, you know, amongst teams, between team members, from management to staff and so forth, just letting people know that you care about what's going on and listening with that intent is incredibly helpful for reducing symptoms of burnout. Okay, next slide, please. Okay, resilience, the ingredients for resilience are connection, purpose, flexibility, adaptability, and hope. And I'm going to talk more about those on the next slides, but just keeping those in mind moving forward, that's what we want to try and advocate for. And those are the things that are going to help really get people through the next couple months in a healthy way, not just in a surviving kind of a way, but we can do well with it. Reminding yourself of what motivates you and recognizing the need to reevaluate that, because I can almost guarantee, you can't really guarantee anything with behavioral health, but almost, that what motivated you in January and February is not the same thing as that what motivates you today. And that's okay. So doing an assessment of what that is and sort of reconnecting with your motivations to find purpose. And then just connecting. We'll talk more about that in a second. And I always am beating the boundary drum. Boundaries, boundaries, boundaries. When you're off work, you are off work. And for those of us in healthcare, it is hard. It is hard, hard, hard to do. But there's this myth, right? There's this myth that sometimes we are the only person that can help that patient. And we need to stay and monitor. And it's just not true. It's a myth for a reason. We all have capable colleagues. We all have people that we can turn to, and we need to use those networks as much as possible. Okay, next slide, please. Okay, scarce resource planning for behavioral health. So looking at what's coming in the fall and what we might be able to do about it. Plan for the behavioral health impact and build that aspect into your surge planning for your jurisdiction or your hospital or your clinic. Look at what happens when there aren't enough resources and sort of prepare for that ahead of time. And you can include de-escalation. I would highly recommend that. I'm going to talk at the very end about some trainings that we offer through the DOH, but de-escalation and staff safety, because when people get, so again, a lot of you probably already know this, but when people are really, really angry, it's usually an expression of an underlying fear. And anger is a lot easier of an emotion for people to access, and it's a lot more culturally sanctioned than fear. So people go to anger right away. And when they don't, when they're afraid that they're not going to get the help they need, they're very likely to act out in anger. And I'm assuming that a lot of you have seen this already. But working on de-escalation and training the staff in how to do that properly and safely is really helpful when resources are scarce. And then one of the trainings that we do offer is this health support team training, which is where we train anyone. You do not have to have a background in behavioral health at all, but you can. And we have a train the trainer as well as a volunteer training for just building up those supports to get, help our neighbors, communities, family members, and friends in a informed behavioral health kind of a way for the next, for whatever. HST, the health support team training, is designed to help people with recovery, with preparation. It's a long-term set of skills and knowledge that you can apply across the board and not just when we're in a disaster. Okay, next slide, please. So resilience development. I was talking a little bit earlier about purpose and connection and whatnot. So what motivates you? What contributes to compassion rewards? Those are things that'll help you find purpose. And then another thing for all of us right now is the need to not think too long-term or too big picture, right? We have to redefine our purpose and make it on a much smaller scale in order to be effective. So, what's going to help you this week? What do you need to do this week or today? If you're thinking about plans for the holidays, that's probably a little bit too far ahead. And adjust your time frame, right? The only exception to this is a little caveat that I add because I work with a lot of teenagers. Teenagers and college students are really, really struggling right now because they have an unclear sense of what the future is going to hold for them and they're scared. And so the only exception to the big picture purpose thinking is if you have teenagers or work with teenagers or young college students, young adults, to really ask them like, okay, what do you want 15 years from now? Think way big picture. The medium term is a little bit more risky, but think about what do you want way out there so that they can start imagining, how they picture themselves in their lives. And that can help with hope and motivation for right now to get through this. The connection piece. So how can you maintain existing connections? How do you develop new ones in the context of a lot of this virtual environment? And then recognizing that the scope of a connection can be anything. It can be to a higher power. It can be to a family member. It can be to a pet. can be to a service group or a colleagues or an organization. It can be anything. When I'm teaching this internationally, we use a metaphor of a tree to talk about the roots of the tree are the connection that you need in resilience. The purpose of the tree is the fruit, and the connection is the roots. And a palm tree has a single taproot that goes down very deep and connects it to the earth. And an oak tree has a huge network of small roots that spread out all over the place. But either way, the roots are providing the connection and the stability that that tree needs to flourish. So it does not matter the size and shape of the connection. It can be anything. We just have to have it as people. And then the flexibility and adaptability piece. So how can you be creative with physical distancing? How can you adjust your physical workspace at home or wherever you are to be more comfortable? And then if you can't adapt your physical space, how do you adapt and be flexible with your time? And that means figuring out how to be flexible, but then putting boundaries around those new parameters. So for example, you know, and I'm just making these numbers up, but let's say you have to work from 7 to 8:30. And then those are like work hours. And then you do parent work from 8:30 to 10 while you're helping your kids with some online school. And then you're back in the other job from 10 to 12. And that might not be a schedule that you ever would have considered before, but now it's necessary. And then you have a lunch break from 12 to 12:30 or something. Go for a walk if the weather and the conditions outside allow you to. And then you do the same kind of thing. And you might, for me, I have an hour between 9 and 10 at night when my kids are in bed that I really get a lot done on the computer. And that used to be a, scroll through Instagram kind of time, but I don't have that opportunity right now. But I find that designating that 1 hour to working and following up on emails is actually really helpful for me. But I have to maintain that boundary around that hour. So at 10 o'clock, I'm done and I shut the computer and I carry on with the rest of life, but it's not something I would have considered before. Okay, next slide, please. So this is a model that I came up with because I love a good acronym, I just do. And so reward, establish, share, and trust is to help resilience development in general. Build in those positive reinforcements for what you're doing. That will help with all aspects of resilience because like I mentioned before, we are not programmed right now to, pay attention to the positive things that are happening in our life and really notice them. Oh, I just turned my camera on accidentally. Sorry about that. Yeah, hello. And then, it can be large or small. The only thing I will mention specifically about the rewards as a positive reinforcement, you got to be careful with substances because a glass of wine might be a reward, but if it turns into a half a bottle or a bottle, that is problematic. So, be careful with the healthiness of the rewards and keep them size appropriate. And then establishing boundaries all day long. I will talk about how important that is. The sharing is about expressing and sharing your experiences and your concerns with other people. That is the smallest thing from if you have an unpleasant encounter with someone at the gas pump or the grocery store, that you don't internalize that, right? You don't keep that to yourself. You share that with anybody, even if it's talking to the cat about this horrible person who said this thing. It just not keeping it in is going to be a helpful process psychologically. And then that last one that I was mentioning, particularly with those of us in healthcare, you got to trust your network. You got to trust the system, and stuff won't always get done. But right now that has to be okay because it is really on all of us to adjust our expectations for what performance and success looks like in this context. We're not doing ourselves any favors to maintain or to try to maintain the expectations for success and performance that we were all sort of used to in 2019 before we were in a disaster, because we can't ignore that. Next slide, please. Okay, so sort of to kind of wrap up, and I'm happy to take some Q&A. I think that was part of the plan. These are the sort of things to emphasize. So getting processes in place for yourself and for your organizations in general that help work on addressing the development of resilience and reducing burnout now in September before we get into November, whatever that's going to look like. Really establishing those norms is helpful. And then, the wildfires have not helped with this at all for a lot of reasons, right? In terms of traumatic exposure to things and the disaster cascade. But people, if you can get outside, if it's safe to do so, when the air clears up, just even a few minutes a day is really helpful for people. So right now it's a particularly challenging time with that, but I just really encourage that. The idea about, sleep and exercise and all that it's cliche for a reason. And deep breathing, like, you know, those things are so overused, but they, you know, they're talked about because they work. So neurotransmitter wise, any bit of exercise you can get is going to help. And then the other thing is about boundaries, right? They're at the top. Take time off and do things that are completely non-work related when you do so, and don't mix those. And that's going to be where you're going to find that good spot. I think that's the last slide. Or maybe there's some references and resources. Yeah. Right. So the two trainings that I mentioned, the one is health support team, and that includes train the trainer. So that can be for people who do have a background in behavioral health, or who are totally, you know, not of that sort of profession, like people that are just interested. It was developed, we developed it in Haiti when we were working with high school and college students who didn't have anything to do after the earthquake, and they just wanted to help their community. So that's how it got developed, and we've since trained hundreds and hundreds and hundreds of first responders and just interested people all over the country and other places. And then this is one that might be particularly interesting to your group, which is called SciStart Responder. It's for frontline healthcare workers of any kind, and it is an app that you use that is confidential, and it records based on, it's really good data that drives this, and it records your exposure, or actually you record your own exposure to certain types of events and situations that can predict the likelihood of the development of new incidence mental health problems. So it's like a radiation dosimeter. It tracks proximity to things, and the more exposure you have, the more risk you're under. And it walks you through the process for developing a care plan for yourself when that's the case. So really cool training. It's only 30 minutes. You can access that through the DOH, and I can provide a contact email when we get done here, if that's of interest. And then other things, I mentioned the family toolbox that we have. We have a group reference guide that has considerations for healthcare providers specifically. We're working on another group impact guide right now. We actually finished writing it a while ago, but it's under review, which takes a little bit sometimes. And that one is about certain demographic characteristics. So essential workers and elderly folks, and how to navigate the behavioral health needs of different members of the population based on those characteristics. Is there another one, another slide? One or two? Oh, okay. That link at the top there is where all of our documents and all of our guidance is kept, as well as the forecast. So we're working on the September forecast right now, and it will be out ideally by the end of next week. But all of our stuff is on that one page at the top there, that top link. And then just the general state resources are there too. The Washington Listens line is also something that we are advocating that people connect to if they just need some support. They are trained staff that then can refer you to professional resources if that's deemed what's necessary based on why you're calling and what's going on there. So yeah, I think that's it. And there's a little bit of time for Q&A if anybody has any questions.
Dr. Mousa, this is Patrick Jones, the facilitator for the group, and I just wanted to say thank you. That was an outstanding presentation. I'm not a clinician, I'm an economist, but it worked for me, and I hope it worked for many other people. And so I've encouraged those, we have close to 100 on the line. And for those who would like to pose a question, I think Dr. Mousa has agreed to be here till shortly before 10, is that correct?
Yes, that's right.
Okay, so any questions that you might want to type into the chat box, or just pipe up and unmute yourself and use audio if that works too.
I guess I would thank you all for the nice comments. I would really encourage you to share as much of this information as you can with other people, because there's a lot of evidence to say that just normalizing what we're all going through is going to help people feel like, oh, okay. I mean, almost every time after I do one of these, people say, I thought it was just me. I thought that I was the only one who couldn't remember what day of the week it was. It's not just you. Oh, there I am. Someone else asked for the link to the health support team. The DOH is working on a portal for that right now, but I can put the email. I got to put the email in the chat there. So you can email the Behavioral Health Strike Team. That's the team that I'm working on. And I will find it. Sorry, okay. Takes me a second.
Thank you for that. Those are wonderful resources, and I think many will check them out, Dr. Mousa.
Great.
So I'm going to go ahead and just speak up.
This is Dan Ferguson. Go ahead, Dan.
Hey, thanks. Really appreciate your presentation. It resonated a lot. I was one of those folks that was on earlier today with my buddy Dan, who I hadn't seen for a long time, so I appreciate the call out there.
Yeah, that's cool.
Anyways, yeah, we actually used to work together in Walla Walla years ago, about 20 years ago, doing mental health down there.
Cool.
So my focus currently, or a lot of my focus and work currently, is really helping health workforce education and those deans, directors, and faculty work with their students. And I really believe that this will resonate with them as they work with their students. And one of our challenges is actually to get kind of our structures and institutions to recognize how challenging it might be to kind of just maintain a status quo as a student. So I'm wondering if you have any comments about that. And I'm really actually looking forward to sharing some of your materials with that leadership group.
So you're talking about college age kids or high school? Sorry if I missed that.
This would be college age. Well, college age is, of course, 20 to 80, right? And so, no, so I'm talking kind of health workforce students across the system.
Okay. So specific information for that population in general?
That's correct.
Okay.
And I'm sorry, and actually for the administrators that run those programs.
Yeah, I mean, I guess I would start by a lot of psychoed around compassion fatigue and burnout, what it is, first of all, and then what you can start doing when you're not feeling that way. It's, it's interesting. It's really hard to get buy-in about behavioral health stuff before people are in crisis, right? Before they start feeling the effects of things themselves. It's this nice thing over here, like the idea of employee wellness, until people are realizing, oh my gosh, our staff is calling out, like people aren't showing up, that kind of thing. So for students who are in learning mode already, just adding that piece into a regular meeting or to a curriculum piece even, that, burnout, this is what burnout is, this is how real it is, this is how it can affect your ability to interact appropriately and safely with patients. These are the risks. And then, because I don't like to focus on that part so much as, here are the risks, but here's what we do about it. So that resilience building piece, I do have another article, another document that our team just published that is about specifically resilience building for individuals, teams, and organizations. And that might be helpful for you to share out with those groups, because I think if you have the opportunity for folks in a learning environment already, they're kind of primed to soak in that kind of knowledge. And if you can add the resilience piece and the burnout piece into that, I think you'll get somewhere. So I will share that. I'll share that resilience document as well. I'm not sure, I can email it to, I don't know who I should email it to. Chelsea?
Yes, yeah, email it to Chelsea.
Okay, will do. And then yes, feel free to share the slides. Several of you asked in the chat about sharing the slides. That's fine. Please do take them and share them and whatnot. Do whatever you'd like with them, that's fine. Brian asked about social isolation support for older adults via Zoom. I don't know of anything specifically, but I do know that the AARP has a lot of really good references and resources. They have been working hard about addressing, support and resources for older adults specifically. So I would check out the AARP and see what they've got. Okay. 211 access. Yeah, sorry, I don't know. Sorry, Jamie, I don't have the answer to that question. I don't know.
So Dr. Mouser, I'm not seeing the specific questions in the chat box. Maybe you are. And if you are, just go ahead and respond to them in the time you have remaining.
Yeah, there were just a few. There were just a few on here, I think. So I put the email for the behavioral health strike team in the chat as well. And I don't think the slides. Yeah, the slides are available. I don't think I've missed anything else. If there's any other questions, please feel free to ask them. Okay,
so chat option or just speaking up?
Yeah.
Please go ahead and do that. Okay.
There's nothing else coming up in the chat that I'm seeing.
All right. I guess you answered everyone's questions.
I guess the only other thing that's worth, for any of you who are working with or have, right, teenagers or young adults, I work with teenagers a lot in my private practice. And one thing that's really essential right now is that communication piece. And there's two things that are really important. Number one is that we are not going to be able to effectively communicate with other people in general, regardless of whether they're teenagers or not, when we're emotionally flooded. So if you start into a problem solving conversation about, like, let's say the daily schedule or the whatever, right, the plan for the household, and you sit down and have that conversation, or you try to, and somebody gets upset and really overworked really quickly, like overwhelmed, you can't continue with it. You have to stop and walk away, because once the limbic system is in charge of those responses, and you're coming from either one, any party in the conversation is coming from an emotionally driven place, you're not going to be able to problem solve effectively. So that's number one. Number two is for teenagers particularly, and I'm talking about 13 to 18. They tend to communicate at the weirdest times. And it's very unpredictable for adults. And what I mean by weird is, like, you know, at midnight and you're trying to go to bed and they come in and say, you know, I want to, like, they just start talking. They don't even say, I want to talk. They'll just start talking. So for adults who, or caregivers or whatnot, who are working and interacting with teenagers, just recognizing that those windows of communication are going to pop up at the strangest times, and to be aware of that so that you can engage with them when on their terms. Because if you wait to do it when you're ready, it'll not work probably. So that's a really weird phenomenon that happens with teenagers. Maybe it's driving in the car, maybe it's at midnight, maybe it's when you're trying to do literally 50 other things at once and you cannot. And just recognizing that that's the window that they are choosing to open, and you got to take advantage of it, because it will close again. Sorry, that's a little off, but I think it's relevant.
So Dr. Mouse, at this, I'll just pose a question. You have done quite a bit of work in disaster relief, where there's a one-time event and then there's repercussions after that. In the COVID-19 crisis, it seems to me that we're dealing with almost an ongoing, rolling sort of episodic crisis. And you know, it started obviously back in March, but it doesn't seem like it's ending anytime soon. So what do you think that means for sort of the path of sort of public community mental health in the state of Washington and the U.S. over the next few months?
So I think what you're getting at is the idea of what we call a disaster cascade, or a trauma cascade. So for the families who have been directly affected or displaced by the wildfires, those are people who are already in the context of having multiple disasters at the same time. Chelsea, I think that's you. If you can go back to the slide on the chart, what I would say about that is that there certainly is a risk for all of us, right? That there's going to be a repeat or another, like a second wave, depending on what happens. Like I hope that that's not the case. But if we have a huge second wave and an additional, like, serious lockdown that happens, let's say in November, what happens with the disaster cycle is that it starts over. So there's a new impact phase, and then the whole process kind of goes out. Even though COVID is affecting people's everyday lives on an ongoing way, we're still actually in the first disaster. So unless there's a wildfire component for people, which there certainly are for some families. So for most of us in the state right now, we're still in one cycle. We're about there. We're a little farther down the curve than it shows on that slide right now. But for the families who have experienced displacement or wildfire, they have had another one on top. And there's two things that happen as a result of that. Number one is that symptoms get more severe and more acute, that whatever they're experiencing is likely, there's a doubling down kind of a thing that happens. And the other problem that happens is that the whole process takes longer. So what you can notice about this is that if given the opportunity, people are incredibly resilient, right? And most of us, just by and large, are going to return to our baseline level of functioning within about 12 to 16 months post-impact. If we get the chance, that's what people do. And that's, again, that's known from all kinds of disasters. If you have multiple disasters that occur within that 12-month and it starts the cycle over and over again, it pushes out the whole process. So then you're looking at 18 months, 24 months. People will still recover, but it will take longer. And in the meantime, their symptoms are going to be more acute and severe. So that is a likelihood. I could say likelihood. It's a possibility for fall. We really don't know. But so far, at least for Washington, and for those families who haven't been directly impacted by the wildfires, we're still on this same chart here. So the evidence for this, the best example is what happened in Haiti in 2010. There was an earthquake in January, a cholera epidemic in April of that same year, a hurricane in September, and serious election violence in November. And that was all within one calendar year. So every time those subsequent events happened, it restarted the cycle. So Shane asked a great question. The call to action is challenging, absolutely. An uptick in overdose attempts, so at the same time, providers have had holes throughout their schedule. It seems that when we advertise behavioral health, it is interpreted as, that is not for me, that's for really sick people. How do we communicate that, yes, it is for you, and it's for all of us? I think that the buy-in that you get is around the way that people are seeing their daily lives affected by this thing. And that is the forgetfulness, the trouble with remembering things, the more quick to anger. If you can get people to recognize that, in fact, no brain is immune to disasters, then it gets them to buy into the behavioral health concept, just initially. It's a place to start. There's no possible way that, because this is the nature of a global pandemic, everybody's affected by this in some way. So getting people to acknowledge the tiny ways in which their lives and their perceptions of things are affected, those simple things like the quarantine 15 and the distractibility and the details, those are things that, everybody can identify with to an extent. So that's what I would start with, just getting that messaging out there and sharing specific examples.
Thank you. We have time for one more question before we have to move on to the next speaker, and Dr. Mouser has to go to her next Zoom meeting.
Yes, I do. I do.
One last question?
Yeah. Anybody?
Okay. Well, again, Dr. Mouser, that was outstanding presentation, and as a testament to I think the topic and your expertise. We've had the largest number of people on a Zoom call that we've had since this started back in March. So congratulations and thank you. Thank you so much. And I know that probably many of us are going to be poring over, or at least going through some of those links you sent us, and probably your slide deck as well.
Well, I encourage you to share it, and I appreciate the feedback. Thank you very much.
All right. Best of luck.
Thank you. Take care.
You bet. Okay, next is Cody Nesbitt from Greater Columbia Behavioral Health, and I saw Cody join us around 9 o'clock, so I know you're there, Cody. And I suspect that you have got the slide deck all teed up with Chelsea, so I'm going to let you and Chelsea take it from here. And just by way of if you all of you on the line saw that as soon as we're done with Cody's presentation, we'll take a small break. So, Cody.
Okay, great. Thank you. I will try to make this brief so we can get to break. That's going to be a tough act to follow. Dr. Mouser, that was fabulous. Thank you for that. Let's launch right into this. So we're going to look at some of the crisis trends for the Greater Columbia area. That's here in Southeast Washington. So here are just a couple of numbers. Okay, but first we're going to start with some of the acronyms that we're going to use and hear all the time. So DCR is a designated crisis responder. Simply put, those are the people who have been designated to perform these civil commitment duties. So they get to evaluate folks who are in crisis and figure out where they can best put them to get them some help. And then below is the ITA, the Involuntary Treatment Act. That's just a set of state laws that we use to get folks some help. So yeah, they get these people with behavioral health disorders in where they can be evaluated and treated. And these are folks that usually are fairly disabled. They're gravely disabled, and they can pose a danger to themselves or others. And they don't typically seek treatment on their own. So this allows them to actually be treated. Okay, next slide, please. All right, here are some numbers. These are just the the big overarching hotline calls that we can see, I have it set up here to compare 2019 to 2020. Not huge differences, but there are some. We haven't seen anything that's overly concerning. So yeah, there we go. Next one, please. All right, so of those calls, these ITA investigations are where a DCR needs to respond to a call. They go out and they see the folks that have called. They are doing their evaluations in the field. And yeah, these are the investigations. So it would be a subset of those calls. Again, I have it set up to compare 2019 to 2020. Okay, next one whenever you're ready. Okay, and here are the DCR response times. A shorter time is better. That means they have responded quickly. Our region does fairly well. There you can see it kind of goes up and down, but for the most part, it stays right around that half-hour mark. So that's pretty good. Okay, next slide, please. Okay, and of those investigations, these ones result in a detention. This is where the individuals have been found to need that extra help. This is where they're put in a facility where they can get evaluated, treated, helped, all sorts of good stuff for them. And here again, 2019 versus 2020. And there are some differences, but still nothing that's really concerning. So that's good so far. We'll see how it goes as we flow down that curve that we looked at earlier. It was neat. Okay, and I think there's one more slide. All right, and this is a subset of that last slide. This just has it broken down a little bit further. So of those investigations that resulted in detention, these are the ones, this just breaks it out, the mental health versus the substance use disorder. So you can see a little bit closer how it's all divided. And I think that's my last slide. Nice and brief. If anybody has questions, I am here.
So this is Patrick. Let me just start the questions, Cody, and ask, so can you summarize those trends? I mean, have you done any analysis to see whether 2020 is definitely worse than 2019? It appeared that just at a real cursory glance at the graphs that wasn't the case, but you may know otherwise.
Right. No, I'm seeing the same thing you are. As far as numbers to numbers go, it's fairly similar so far. But we do see a lot less of the face-to-face contacts and a lot more folks just kind of doing their own thing and then only calling when they're in crisis. So you would kind of think we'd see more, but so far it's held fairly steady to what we expect. Kind of odd, actually.
Okay. Yeah, that would be my takeaway from those slides as well. Okay, so questions of Cody about, now can you just describe the geography of your organization? Isn't it more than Benton and Franklin counties?
It is, yeah. So we're made up of, let's see, we have Asotin, Benton, Columbia, Franklin, Garfield, Kittitas, Walla Walla, Whitman, and Yakima are all of our counties. So I think we have 9, right? Yeah, 9 counties. So we're pretty big as far as geography goes, but we're not as big as King, say, in population. So
right.
Yeah.
Okay.
Patrick, this is Carol. I have a question.
Go ahead.
Yes.
Yeah. So the BHASO are the same boundary lines as Greater Columbia ACH. So that was intentional as a Medicaid purchasing area. So I think the information is really relevant to our region. And Cody, I'm thinking that, you know, some of the reasons we might not be seeing this big uptick is that we're not really squarely in the phase yet that Dr. Mouseth was talking about. I think we're still, you know, we're approaching that drop, you know, where disillusionment really settles in. So given that, what is the behavioral health organization doing in preparation for that? Knowing that, you know, we're approaching where we might be receiving a lot more calls. Are there suggestions for those of us in, you know, in healthcare to assist the BHO? What are you guys doing in preparation for the cliff?
Yeah, that's a great question. Well, as always, we try to remain in constant contact with all of our providers. And if anybody needs extra resources or put in touch with somebody, we try to facilitate that. Make sure everybody at the provider level has all of the equipment they need, that they're staffed appropriately. If they just have questions for us, we try to be there for that. Really, we just try to be as supportive as we can overall, just to make sure that we're ready. It's kind of hard to plan, you know, in depth this far ahead because we don't really know what's coming. We don't know what's going to spike where, what's going to happen, who needs what. So we just try to be ready, and yeah, try to help where we can.
I just have one follow-up question to that before you get the chat question, which is uptick in suicides. Are we seeing that in our region, or suicide attempts?
I don't have the data for that across my desk, but yeah, I would imagine. Well, actually, we do have a little bit of, yeah, I guess our call metrics can show a little bit of that. There are some, I think we're down from last month was like 30% of the calls had something to do with that. We're down to 15%, I believe, this last month. So it does fluctuate. Yeah, it's all over the board, just like everything else, I guess. People deal with stuff in all sorts of ways. So like the spousal abuse that was mentioned earlier, we have seen an uptick in that a little bit on our call metric stuff. So yeah, it's just, it does fluctuate.
Thank you.
Sure.
Okay, so we have a question from Jack Davies. Do you see that, Cody?
I see that. Is there a way to collect other data that could help track an uptick in behavioral health or mental health issues, such as ED visits? I would imagine there would be. We don't touch the ED stuff. That's fairly separate from us. But yeah, let's see who has access to that. Carol, does the ACH group have any access to that? Or I know you guys have helped facilitate some of the, oh, what was that?
Yes, our data is typically lags. Maybe Wes can answer that question, but you know, my understanding of the data that we do get from the Healthcare Authority is somewhat lagging. The Benton Franklin Health Access team used to get more recent information just for local hospital utilization.
Okay, that's what I must have had in mind. Yeah, we lag too. Data flows through the providers to us, and then eventually, you know, out. So yeah, there is a lag. I feel you.
Hey, Carol and Patrick, this is Jack Davies. Can you hear me?
Yes.
Yeah.
Yes, go ahead, Jack.
Part of the reason why I asked that question is given all of this information and knowing full well that the typical data systems do lag, is it worth setting in place some sort of short-term alert or warning system that maybe would use ED visits or other data that wouldn't necessarily raise to the level of calling in a crisis counselor, but could give some early warning sign that we really need to be focusing interventions in particular communities. I think that that's something we should think about very seriously.
I think it's possible, Jack, and I think you raise a really valuable question in that the best data is always local, and so I'm wondering if our local health improvement networks across our region could try to access that data. Would certainly be willing to help them access that data. I know that Collective Medical is a tool that is being used by all of our providers that are under contract and behavioral health providers that are under contract with Greater Columbia as those warning signs about when people do go to the emergency department. So I'm thinking that the providers under contract are at least being able to track it through Collective Medical. Perhaps one of the navigators could add to that. Or not.
No ACH navigators on the call. Sam?
Hi, Carol. This is Martin. Can you repeat that question again?
So, Martin, we were wondering if your providers that are under contract are using Collective Medical to really track emergency department utilization as kind of warning signs.
They are tracking that, but I'm not sure if they're really using that to kind of, look ahead and say, hey, we're going to have a surge during this time. I do know that they are aware of kind of the months that they see kind of as a peak, of when they say, hey, during this time, which is usually, probably like around the fall times when there's that weather change, that they're able to kind of predict, hey, we're going to get a little bit more calls or see more patients. But as far as utilizing Collective Medical, I'm not sure if they're using it for that purpose. But they are, for those that have been able to implement Collective Medical, they for in the behavioral health side, they are looking, as to even if, I'll mention Merit, for example, if one of their patients goes to the hospital and they get that notification, and they're getting that notification regardless of, the cause for them to go to the hospital. And what they do is they do look into, hey, can that be a possibility of maybe substance abuse or, a behavioral health, response to something that he was, he broke his hand or, something happened to that individual. So that's how we're seeing, the behavioral health sites use Collective Medical.
Patrick, it looks like Penny Bell had a response in the chat box too. I don't know, Penny, if you wanted to pipe in.
Okay. Penny, I didn't see that. Thank you, Carol.
I will read her response in case she's not able to pipe in, but Penny said, ideal balance. We are using Collective Medical to track ED visits and receive EDI reports from data that we submit to them. So ideal balance looks like they're tracking it through Collective Medical.
Okay. So
okay, sounds Carol, like I'm unmuted now. This is Penny.
Go ahead, Penny.
So yes, we're using Collective Medical, and we submit a file once a month of all the patients we served in the previous 30 days. And then we get EDI reports from Collective Medical, and then we're following where we reach out to them within 72 hours or 7 days, depending on if it's an ED visit or hospitalization. So it's working really well, and we've got it set up so that it's the three hospitals within the Tri-Cities, Lourdes, Trios, and Cadillac. So it's been really a smooth process. Those EDI reports are faxed to us. And so we have somebody that pulls them and goes through them. And it took quite a while to get this set up, but we finally have it running. And that's how we track it. I don't know, I can't really speak to any lag time. I haven't really tracked that. I will now that I'm hearing that verbiage to see when they were actually at the hospital versus when we get the report. But we get them every day.
Okay. Thank you, Penny. And can you just tell the group again who you're with?
With Ideal Balance. And Ideal Options doing the same thing. Victoria's on this call as well. So we both have this set up. We're both the MAT part of the business and then the behavioral health.
Okay, great. Thank you. Melissa Haney, do you want to elaborate on your comment about CMT users?
Sure, I'd be happy to. I'm Melissa Haney. I'm from Northwest Physicians Network. So we've been using the collective medical technology ambulatory tool for about 4 years now, and we use it for a variety of purposes. But one of the things that we do is that we get a daily report on all patients that are within our network that present to the emergency department, and that can be any emergency department, with suicidal ideation or a suicidal attempt. And so we have a process for reaching out to those patients to make sure that they are connected with services and potentially case management. And I'm not sure, we could potentially like track if we're seeing a rise. We tend to notice it because we have someone who looks at the reports all the time. But I just wanted to let everyone know. So if they are actually using the collective medical technologies ambulatory tool, they can ask CMT to have a file that's sent over, and they can select the cadence of the file for members that present with SI or SA.
Very good. Thank you, Melissa. Does this information help you, Jack?
It does, and I'm also looking at the report that somebody listed the link, which is the DOH Behavioral Health Impact Situation Report, and they're tracking ED visits for psychological distress as part of their syndromic surveillance system. So I think that it's good to know that A, there are reports available, and B, it's possible to drill down a little bit closer using systems like CMT. I think that then the next question, and it's one I think Kel's right to discuss at the LIN level, is how do we monitor this information in a way that we can plan, if it's appropriate, try to plan responses in a way that will hopefully keep the curves low.
Okay. That is a good question, and hopefully you can have that discussion among your particular LIN and those of you on the call who are also participating in your regional organizations. You might consider that as well. We do have a question from Matt Kumpel. Matt, do you want to pose your question, and then we're going to have to wrap up here in a couple of minutes.
Yeah, thanks. One of the question that I have really has to do, and I apologize, you might have addressed this earlier and I was running a little bit late, but there are, we have a number of clients that we work with in the WISE program where we are providing intensive services, and they may have suicidal ideation or all of those other things, and may not actually ever reach the level of needing to go to the ER, or do not get the kind of response that they are hoping for from CRU. So we're dealing with that at an agency level, and I don't know that data would ever get rolled up so that it could roll back down into how many of these are actually going on in the area, like how many therapists or other providers are helping and providing support to clients on that ground level before it escalates to going all the way into the ER when there has been an attempt already, or an attempt requiring medical attention, all of those kind of things.
Thank you. And just by way of background, Matt, you're with what organization?
Lutheran Community Services. We're in the Tri-Cities area office.
Right. Yeah, I thought I recognized your name, but sorry about that. Okay, we have time for one last question before the break, if there is one. I don't see anything in the chat box. Do you, Chelsea? I think that's empty or been taken care of anyway.
Patrick, this is Carol. I just wanted to respond to Matt's comment, and thank you, Matt, for that that comment. I think one way that we could address that is that Diane has her monthly behavioral health meetings, and maybe this is something that we could actually talk about, because it would be the providers that would know when they're receiving those calls through their agencies, and maybe there's the opportunity for us just to talk about, you know, what are we seeing through our community agencies with regard to these calls, because you're right, they would not escalate to the emergency department. So it could be something internally that we could share.
All right. Well, we are at a quarter after the hour, and we will be back at 10:25, as you just saw that the posting that Chelsea put up. And so don't go away, but come back after your cup of coffee or whatever. And we look forward to hearing Paul McNaughton from Comprehensive Healthcare give us his take of the opportunities and challenges of behavioral health and mental health in our region. So we'll see you all in 10 minutes, so to speak. Well, hello, everyone. This is Patrick again. It's 10:25, and we like to stay on schedule. We have I think, a very promising presentation from Paul Nagel-McNaughton coming up, and wanted to give everyone time at the end of our session here for a little Q&A and asking hard questions of Paul, Cody, or Dr. Mouseth's counterpart from DOH, who I think is, I don't know your name, but if you would like to just introduce yourself when that time comes, that would be great. But why don't we go ahead and get started? As you can see from the agenda, this is recognizing and then meeting the challenges of behavioral health from a very senior person at Comprehensive Healthcare in Yakima. So Paul, I assume you're on the line, and are you ready to go?
I am here. How's the audio sounding?
It sounds good to me.
Excellent. I appreciate you inviting me here this morning. My presentation is going to tie in real nicely with Dr. Mouseth. I'm going to kind of dive in a little bit deeper on some of the things she talked about, and really want to take a look at how are behavioral health concerns playing out in our communities right now, and then more practically, what are some things that we can do about that? Because we do know, as she mentioned, that we are moving forward toward, again, that fall when we may actually be seeing more impacts as the clouds get darker and or the days get shorter, and that the trough that she was talking about in that diagram comes a little bit closer. So I'm going to talk a little bit about kind of an approach to whole health and again, what are typical responses to crises, and what are some tools that are out there to address those, and how can we support our employees, our essential workers during this time. So one of the things that I think COVID-19 has done is help people make that connection between my personal health, my mental health, and the whole health of the community that we're in. That we can really see those clear connections as back in March and April, when beds were really starting to fill up at the hospitals, and that I need to do actions to protect myself, but I also need to do it to protect the community. We're getting ready to do some marketing right now around getting flu shots, both for our staff and family members. And that's going to be critical for individuals because they need to stay healthy. But really, it's going to be really important for the whole community because we need to protect the limited healthcare resources we have. And the more individuals we can keep out of hospitals, primary care clinics, because of you're getting that flu shot, the healthier the whole community is going to be. And the limited health resources that we have are going to be able to focus on the COVID-19 cases as they return. I really like this slide because it really kind of focuses on what are some common responses to pandemics and disasters. And the piece that I really want to make sure people hear is resilience is the most common response to disaster. That yes, people are going to develop distress reactions, sleep difficulties, that irritability, that quick to anger that Dr. Mouseth was talking about. We've got some at-risk behaviors that are going to develop, whether that's increased alcohol and tobacco use, which we know is going on from the increase in sales tax around alcohol and marijuana that the state's tracking. And there's going to be a group that will develop, true psychiatric disorders, but that's really pretty much a small piece. That really everyone's being impacted in many ways, but resiliency, we need to understand that 2/3 of the individuals are going to respond to disaster with resilience. That most people, again, that's the normal response is resilience. It's ordinary. It's actually common to respond in that way. It doesn't mean that I'm not distressed. It just means I'm able to cope with whatever those challenges are better because I've got those skills. And many people think of resilience as maybe it's a personality trait. It's something I have or I don't have. When in fact we know resiliency is a skill set, and it can be taught and it can be learned. And the training that Dr. Mouseth talked about earlier, those are all tools that we can use to help people build their resilience. So one of the metaphors I want to think about is what is that cumulative stress, that sort of cascade disaster that Dr. Malsas talked about, that it's, if we think about it as a pressure cooker, that we are not just experiencing one stressor, we're experiencing stress after stress after stress. And the human body is just not meant to cope with that sort of cascade of things. I was on a call earlier this week with one of my colleagues from Walla Walla, and she actually made the point that in their community, the disasters really started in January with the extreme flooding. And so we had flooding, we had COVID-19, we've got job losses, we've got fires. And so again, that cumulative stress really is different than kind of the normal stress. When we look at stress, we know that there are different parts of our body that respond to stress. And so in normal stress, we have that stress system that kicks in, that threat system, but then we have our relaxation response, that soothing system. And it's that balance of being able to experience the stress and then recover from the stress that's critical. But when you have that accumulation of stress, that pressure just keeps rising and rising and rising. And so that's that threat system is the limbic system that Dr. Malsas was talking about earlier, that flight or fight response and quicker to anger. And really having to take extra work to acknowledge the drive system, that we aren't getting those positive, or we're not hearing the positives as much as we used to because we're being overwhelmed by that limbic system. So taking that extra time to hear the positive feedback, understand the positive things that are going on, and celebrate those. Common ways that we're experiencing stress after a disaster, kind of the recurring thoughts or intrusive images coming back to mind, wanting to escape or avoid potential triggers. Our body reacts in all kinds of ways, and that hypervigilance really causing us to over-respond to things. If you think about cumulative stress and living in that stress response, it's sort of like driving your car around in first gear all the time because you're not getting into that relaxation response. And it's not like cars can't operate only in first gears. They can, they work perfectly fine. But what happens when you drive your car around in first gear all the time? Well, you burn more fuel, more oil, your parts start breaking. And so our bodies just can't live in that revved up state all that time. And we got to figure out ways to get into that calming, soothing response. So in the limbic response, that flight or fight response looks a little different when we think about a pandemic. We got the fight, flight, or freeze. Those are the common responses to stress. And so what does fighting look like? Well, we saw a lot of that early on with that rallying, supporting our essential workers, fighting for access to care, addressing disparities, and other ways that we're sort of outwardly acting. We also have people that respond by flight or running away. How does that look like in a pandemic? Oftentimes that shows up more as isolating, pulling away, or flight into drugs and alcohol, flight into social media, Netflix binging, whatever it is that we're running into. And then freezing, that sense of just being numb and just being overwhelmed. There's just so much out there that I don't even know what to do. That it may be some inertia. The other thing we've been talking about is how do psychiatric disorders look different in a pandemic. It's two common symptoms of depression are isolating and withdrawing and not engaging in activities that used to be pleasurable to me. Well, those are signs and symptoms of depression, but they're also signs and symptoms of isolating and responding to a pandemic. And so how do we really start recognizing problems when some of it may be going on behind the scenes? I think most of us are probably familiar with the stages of grief and loss: denial, anger, bargaining, depression, acceptance. And in a typical loss situation, you might work your way through that. But what we know is that the healing doesn't happen in a nice, tidy order. And that's why there's a kind of lines in the middle of the diagram, as you can jump from one stage to the other as you're going through the healing and mourning process. But what does it mean to be in the middle of a loss that's not resolved, and either an ambiguous loss or a limbo loss? Well, you're much more likely to jump between the different stages and not come to a resolution. And part of that cumulative stress that we're under is that people have experienced what I would call complex or limbo losses. Maybe I'm no longer in the workplace because my job went away, and I may or may not be going back, and I don't know when that's going to happen. I have a business that I've had to close or downsize, and it may or may not grow or come back. And so lots of us are sort of in the middle of these limbo losses, and sort of cycling back and forth between the different stages. And there's also less tangible losses that people may not even be aware of that they're experiencing as losses. I have a loss of safety, a loss of freedom, just a loss of predictability about what the future is going to be like. And so all of those things really can make moving through the crisis process that much more difficult. We don't want to make a distinction between grief and mourning. And mourning is when the healing happens. Well, what happens when the cultural practices I used to engage in around grief and loss can't happen? We can't do live funerals. We can't engage in healing and mourning ceremonies in our communities. That keeps people stuck in those losses. One of the metaphors I've been using with folks around COVID-19 is the COVID-19 lens. That what we're looking at the world through right now is this lens that's been impacted by those cumulative stressors or those cumulative losses. And when I look through that lens, things get distorted. They look bigger than they should be. They're more threatening. My feelings that I'm experiencing are deeper or more intense or more immediate. That flash to anger that Dr. Mothsess was talking about, that more immediate things. And helping people think about that lens when they're looking at themselves and saying, hey, I used to have the ability to cope with things better. Why can't I deal with this? I'm finding myself being more emotional. It's like, well, yeah, that's all true. But what you're seeing, your response to the situation, again, is being distorted by that lens. And so helping people understand some self-forgiveness and some permission to have whatever those feelings are, and understand that would it be if we weren't looking through the world in this lens, things would differ. And then you layer on top of that compounding challenges of the social isolation. We're not able to engage in those, again, communal healing and grieving rituals I talked about. We know that there are disparities in terms of access to care and who's being impacted, both in health impacts and economic impacts right now. That those the impacts tend to be individuals with people of color, lower income folks, individuals that work in essential industries where they can't not go to work, and so that just gets compiled on top of the other losses, and that just intensifies that lens in which we're looking through things. So what can we do? And so we're looking at how do we intervene in our communities? How do we provide some education, support, teaching in ways that are going to prepare people to cope as we again move into this fall, and we are expecting escalation in behavioral health symptoms, increase in suicide, domestic violence, and in those areas. So a number of things that we and others are providing. We have suicide prevention trainings. We need to have lots of people trained in our communities on how to talk about suicide, how to ask the question, and how to connect that person with resources. Mental health first aid, I'm going to spend quite a bit of time talking about that, what that looks like, where it comes from, and how we're currently using that in communities. I'm going to touch on psychological first aid. That's a model that comes out of the World Health Organization. It's the background for some of the work that Dr. Mothsess is doing as well. She mentioned health support teams, the training that the Department of Health is providing. And then a new term that I just came across the last couple of weeks is psychological PPE, that we've really been focusing on helping people stay healthy by giving them protective gear. We got gloves, we got shields, we got masks. But what are we doing to help people on the psychological end of things? How can we help them develop those resiliency skills? Because we know that those challenges are going to continue in our communities. Someone asked a question earlier about how do we get people to access services? When we mention support, it's like, oh, that's for someone else. That's for someone who's mentally ill. So this is a campaign that Bring Change to Mind started way before COVID-19 even hit, but I think it's become even more relevant today, that we are all impacted by this. As Dr. Motza said, there is no brain is immune to what we're going through, that we are all in this together. We're all experiencing stress and distress. We're all experiencing the impacts of change, and we all need support. And this is not, something for other people or that group of people over there, that we are in this together, and we need to make sure that we are as healthy of a community as we can be by attending to our own personal health and wellness, both on the physical health side as well as the behavioral health side. So one of our big concerns as we head into the fall is increased suicide rates. There is some early anecdotal evidence collected through different coroners' offices that there is a spike in suicides. We know that's true in Yakima County. There's an increase over the baseline from past years. Again, we don't have enough data to firmly say that yet, but we know there's a strong connection between mental health and physical health. I'm aware of 2 suicides in the last month in our community that were directly connected to the individual's loss of health. And so really attending to the fact that we can't separate these two. And what we're looking at is, are we experiencing a crisis of hope? Because we know that sense of hopelessness is a powerful red flag when it comes to suicide, that we know hopelessness corrupts and absolute hopelessness corrupts absolutely. And so when we're doing suicide prevention, what we're doing is, again, restoring hope to those individuals that don't really see there's a different way out for themselves. We have a training called SAFE, Suicide Awareness for Everyone. We really try to use the acronym SAFE because more people will come to a training if you call it SAFE. If you call it suicide prevention, get less interest that way. So part of that's a positive marketing piece. That we know that suicide is a public health issue. It's not a mental health issue. It's not a behavioral health issue. It really is a public health issue. We need to treat it as such. And that means we need to have as many eyes in the community, as many skilled and trained individuals in the community that have gone through basic suicide prevention training. So if they bump into someone during their day-to-day activities, they know what to do. They know the questions to ask, and they understand how to connect that person with resources. So our SAFE training is based on a curriculum that comes out of the QPR Institute in Spokane. Dr. Paul Quinnett developed it years ago. It's widely used in Washington as well as around the country. We really can tailor this presentation to a variety of different audiences. We used to do it, lots of in-person training, but obviously we can't do that now. But what we're really doing is creating a space for people to ask the important questions. That are you okay? How are you feeling? What's going on? And make that a routine part of what we're doing. One of the women I worked with, I was doing a debriefing with her. She was happened to be someone that discovered an individual who died by suicide, and so was processing through her own response to that. And what that did for her was to increase her commitment to making sure she was asking that question in routine conversations. This is not something I'm doing because I'm necessarily worried about you or something I saw or heard. We want to make sure that this is part of my everyday conversations that we're having with people. That, are you okay? What's going on? Have you been thinking about suicide? Is that something that's crossed your mind? We need to make this, again, part of our routine questions that we ask about. So QPR stands for Question, Persuade, Refer. We teach people how to ask the suicide question. Are you thinking about suicide? Have you thought about killing yourself? Have you considered what the world might be like if you weren't here? Different ways of asking the question, and then subsequent follow-up questions as well. Persuade that person that there is hope, that there are resources, that we can get you connected, and then referring that person to those helping resources. So the QPR training is pretty short. It can be an hour, typically we like an hour and a half, maybe to cover risk and protective factors, and then how to do the question and persuade piece. We also do the training for clinicians. When we do it for substance use professionals, counselors, other health professionals, we do QPRT. We add treatment on the end of it, and that's a longer 6-hour training. but really, again, connecting people and empowering them to ask the question, because that's where it starts. And if I'm afraid to ask the question, or I don't know how to ask the question, or I'm scared what the answer might be, it's really, again, giving people the skills and normalizing having conversations about that topic. Another resource we have is mental health first aid. And this is a curriculum that's sponsored by the National Council for Behavioral Health. They do the training. It's an 8-hour training that really looks at how do we identify individuals who may be distressed, how do we understand what those signs and symptoms are, and then again, what are those skills I need to be able to step into that crisis and help that person. Much like we're able to do CPR, it's we're not teaching you to be a doctor, we're not teaching you to be a therapist, we're teaching you those basic skills that you need to step into a situation and maybe change the course of that for that individual. Obviously, we can't cover every diagnosis or every behavioral health issue in one training. So really are focused on depression and mood disorders, anxiety, trauma, psychosis, and substance use disorders, and what those look like, and how to support someone that may be experiencing that. For the youth mental health first aid, we go into a little more detail on adolescent development and what kind of mental health problems are more common in youth. The interventions that we're looking at teaching folks with mental health first aid is how do you help someone who may be experiencing a panic attack? What if they're having suicidal thoughts or behavior? What is non-suicidal self-injury, those self-harming behaviors, and what can you do about that? And they have a set of role plays and activities, so it's really a skill-based training. A little bit of a challenge online currently, and I'll talk more about that in a minute. But when we're able to do it live, really getting people into roles and practicing and learning skills. They have a particular acronym that they used in each of the situations. So there's a 5-step action plan for each of those areas we just talked about. So what's your 5-step action plan for panic attacks? What's the 5-step plan for suicidal thoughts and behaviors? The little koala bear there is that's our mascot, Algie. Algie is a koala bear because the curriculum was originally developed in Australia, so that's a nod to the down under Australian roots of the training. So each time, whether it's suicide, panic attacks, psychotic symptoms, we walk people through the 5 steps. We're going to assess how do you listen non-judgmentally, and Dr. Malstadt talked about that too, is that non-judgmental listening is so critical right now. Give reassurance, encourage appropriate connections for support, but also encourage them to engage in some self-help and natural supports as well. We know that youth have particular challenges, and so we have adult mental health first aid, and we also do youth mental health first aid. And there are some, again, developmental issues around teens and how they behave, and how behavioral health issues manifest in that group. And we really know that suicide is a huge leading cause of death for individuals in that 15 to 24-year-old range. And so that's a critical issue for people to know about and to have the skills to help someone that may be feeling distress. One of the nice things that the National Council for Behavioral Health has done, along with the mental health first aid, is develop some great talking points and targeted messages around different populations. So teens, how are we helping teens cope during COVID-19, and what are some specific pieces they need to know about, including limiting your exposure, that you don't have to be plugged in to social media and news media 24 hours a day. There's other things you can do for your health. And when the smoke goes away, we'll be able to go outside and do some of those things again. Then we got some special messaging around anxiety and depression, because we know as part of COVID-19, those are 2 disorders that really are popping up for individuals, that they're feeling more anxious, they're not sure what to do, depression, what that looks like, how do we intervene with that. And people are really struggling right now with what's normal anxiety and what's abnormal, what's something I should get treatment for. What is, we're all feeling a little bit down right now. Is that normal? What does that look like? And it really comes down to that interfere piece for both anxiety and depression. How is that? How are those symptoms interfering with your daily life in terms of work, school, relationships, all those things? If once it escalates to the point of interfering, and then we need to be talking about it. And that's what we're really preparing for as we move into the fall, is more and more people are going to need access to behavioral health services, and how do we prepare our communities for that. More of a young adult messaging with this one, some similar pieces to the teen one, keeping yourself healthy, exercising, being kind to yourself, showing that kind of self-compassion that I talked about earlier. We know as healthcare workers are particularly impacted right now, both because they're putting themselves on the front line, they're seeing the impacts of COVID-19 directly. How do we help healthcare workers recognize that special role they're playing, practice some of that self-compassion, having those feelings, whatever those feelings may be, and again, helping our brain step into the positive, because again, it's worn down. We're less likely to see the positive. So again, helping us hear that positive feedback, see the value in the work we're doing, and celebrating that. The mental health first aid training also come in some different emphasis. We have one that's on law enforcement and first responders, the public safety version of mental health first aid. We've got Morgan Grant, who's a retired law enforcement officer who works as our law enforcement and justice liaison. He and another one of our trainers are certified in the public safety one. We know that suicide rates among first responders and law enforcement officers is really high, and they tend not to seek as much support. And so there's a couple pieces in the mental health first aid for public safety that really talks about that and addresses that, and teaches skills for reaching out to your coworkers and talking about these things and building some peer support in the workplace as well. Our biggest challenge with the mental health first aid is that you can't do it live anymore. And so National Council rolled out this summer virtual mental health first aid classes. We're about to offer our first couple this month. And what they've done is divided into two components. There's a first part is an online kind of independent study course that participants need to take before they can get into the online facilitated discussion. And so we send out basically a code to the individual who's registered, and they go online and do their independent study piece first. And then we open them and invite them into the facilitated discussion with our trained facilitators. So it's about an 8-hour training. Still, it's a little different for youth versus adults. Still trying to do hands-on as much as we can in terms of role plays and participation. Well, I'll know more in a couple of weeks how that's going. We've established partnerships to offer mental health first aid throughout Eastern Washington. We're starting to develop that calendar now. Again, it took the National Council a little bit of time to work out the kinks with the virtual classes. So we're anxious to get that calendar built so we can provide these trainings throughout our service area. So resilience is a skill, and psychological first aid is about building those skills. And earlier, we walked through some of these building blocks, if you will, around psychological first aid. What does that look like? Establishing a sense of hope, a sense of efficacy for healthcare workers, that I am valued and I understand that it's difficult right now, but the work I'm doing is really promoting community health as we go forward, and connecting and having making time to make those connections with coworkers. As she talked about, are we creating time even in our virtual meetings for us to connect in more meaningful ways? This is another piece of the mental health first aid training around, how do we know, healthy coping versus not so healthy coping, and just being able to get some messages out to our coworkers, the people we serve, and the community around what does it mean to practice good resiliency skills and good healthy coping skills, and making sure people aren't spending too much time in the unhealthy column, working too many hours, consuming too much drugs and alcohol. We know that learning coping skills is an important part of resiliency skills. Are we creating opportunities for having conversations about coping skills, building resiliency, getting support in our day-to-day activities. Are we doing that in the workplace? Are we doing that with our families? Are we doing that with the people that we serve? And what does that mean? Well, there's a huge menu of coping strategies, and I need to find those ones that work for me and develop a personal wellness plan built around which of those coping strategies are gonna work best for my situation. One of the things that we've been doing at Comprehensive Healthcare is trying to create sort of mini opportunities to have conversations about employee health and wellness. Back in May, for May is Mental Health Month, we had a yoga instructor come in, and we did sort of virtual yoga at your desk. What are things that you can do on a day-to-day basis to move your body and work through some of the stress that's present in your physical body? We did a WebEx session on employee resilience, where we did a brief presentation at the beginning, but mostly focused on a conversation amongst employees who jumped on the call. We offered 10 different sessions in a particular week to try to hit all of our different shifts, but again, creating a space to have a conversation. Just this week, we pushed out a 5-minute meditation video. Take five for yourself, and get into that relaxation response, even if it's for just a few minutes. I really like this slide because it addresses the issue that we keep talking about. People need to get support. You need to connect. You need to get support. But it's important to realize that support comes in different flavors, and not all social support is the same. And you need to be clear about the type of support you're asking for, and make sure that the person that you're interacting with gets that. That if you're looking for emotional support, but what they're offering is problem solving, that's a mismatch, and that's likely maybe to create some frustrations for you. So what kind of support do I need right now, and who's going to be the best person to do that? In our neighborhood, we're really looking at how do we provide physical assistance to our neighbors. Windstorm that came through and knocked a bunch of branches down. We've got neighbors who can't clear those branches. So how do we provide that support to our neighbors as well? I'm hoping that many of your organizations have employee assistance programs, and this is a really good opportunity to promote that employee benefit if you have it. It's the perfect time to have a benefit like this for our employees, especially if we can connect back to that the no normal message that we are all in this together. We all need support, and as a caregiver, you can't give away what you don't have. And so if I'm not caring for my own health and wellness, I'm not going to be able to be there for those that I serve. And so how are you filling your tank? How are you making sure you're taking care of yourself and you're getting the support that you need, so you can really be fully present for those that you're providing care and support to? EAPs are great because they provide that individualized support. They tend to be very brief and solution focused. So by promoting EAPs, if you have them, it really is sending that message that we believe in self-care, we want to support you. Many EAPs are doing services through telehealth right now, so that barrier, how do I access that care, is really, really low bar to connect with a counselor. And again, getting that message out that we are all in this together, that everybody needs support, and reducing some of that stigma people are feeling. I thought this was a really cool example of messaging about how do you make that transition from workday to home. That before you leave here today, just take a minute to think about the day. And what's one thing that you just need to let go of? What's something that's heavy on your shoulders that you want to shake off and leave behind? What's something you can be proud of today? That messaging, that positive stuff, and getting the frontal lobes to engage and think about the positive stuff, even though it's feeling pretty exhausted right now. What are 3 things that went really well? Do you need to check on your colleagues? Have you noticed one of your colleagues maybe not doing well right now, that you need to reach out and ask how they're doing? And take a minute to reflect for yourself. Do you need some support? Is there something that your supervisor can provide to support you? And once you're done with that checklist, take a deep breath, switch your attention toward home, those good boundaries that we were talking about earlier, and rest and recharge, because we need you back tomorrow. We need you back with a fuller tank than you're leaving with probably right now. So again, helping our employees make those transitions from the workplace that is very stressful right now, to home. This was already mentioned earlier, the Washington Listens line. If you don't have an employee assistance program and you've got folks that need to talk, our organization is providing staff to this program, as are behavioral health organizations across the state, to support this line. It's not a crisis line. It's really a support line for individuals who are experiencing elevated stress due to COVID-19. If it is a crisis, they'll connect them with a crisis line, but they also have access to other resources. What are the resources in your community that you may need to reduce your stress? If you have questions about anything I've talked about today, I've got our sort of a generic email up there. You can send an email to info@cophc.org. My slide says questions and answers and more questions, because things are going to keep changing and we're going to keep probably having questions. And as we negotiate the uncertainty of our future, having opportunities like this to ask questions, pose questions, think about how do we support ourselves, our coworkers, and our community are going to be critical. That the challenges that we are going to face are huge, but so is the capacity for resilience and pulling together as a community. And that's, again, for me, that's the important part of the message, that yes, there are challenges ahead, but we know the resiliency of the human spirit. We know what we can do when we work together, and we need to keep getting that message out as well. So that's my presentation, and I'd be glad to take questions, or it sounds like we have other folks on the line as well. We were threatened with some tough questions. We'll let the other guests take the tough questions. I'll take the easy ones.
You might be one of the few people, well, Dr. Mouse at the left, so we can't put the tough questions to her, Paul. Thank you. That was excellent. I'm going to review that just on my own and introduce it to my staff. I thought that was great. I appreciated the emphasis on how to respond to all these stressors that we're dealing with, and I'll be chewing that over, and I hope I'm speaking for many on the line that they'll be doing the same. We have one question in the chat box, and that's from Victoria Evans, and she writes, can you tell us the difference between mental health first aid and psychological first aid, and which might provide more value for those people working in behavioral health fields?
Certainly, yeah. They're again, they're two different things, though there certainly is some overlap. So mental health first aid really is that structured curriculum that talks about, again, it's more of a full 8-hour training. It's a kind of a compartmentalized training that is provided to community members, professionals. One of the nice things about the mental health first aid, one of the significant outcomes of individuals that complete mental health first aid is this reduction in stigma. That people come into the training with certain beliefs about what mental health is, what is addiction, and they leave with a much more compassionate understanding and a much more willingness to reach out to individuals who are maybe experiencing emotional crisis. Psychological first aid is sort of a larger approach to community intervention. Many programs have borrowed concepts from psychological first aid. If you just Google World Health Organization psychological first aid, you'll see all kinds of resources, including community manuals, skill-based activities. The University of Washington really has done a great job of taking those concepts of psychological first aid and packaging them into some trainings around that. The health response team that Dr. Mouse talked about earlier, I'm pretty sure that has its foundation in the psychological first aid materials. So one's more of a contained training. The mental health first aid is again more specific, one-shot training, where psychological first aid is a much broader, either organizational or community approach to dealing with responding to disasters in the community.
Okay, that's helpful. That's helpful. All right, I haven't seen any more entries in the chat box for Paul, but I'll just throw the floor open for those of you who haven't bothered to write something down, but you'd like to speak up. So Anybody on the call would like to ask a question for Paul?
I should share my camera because I have a lot less hair now on my head than I had when that picture was taken, because I'm cutting my own hair now because it's COVID-19 and I can only cut one length. So.
All right. Yeah. So here's a question that Chelsea just put up. What should we do if there's a lack of psychiatry in the area for these sorts of needs?
Yeah, that's a huge challenge, not just here locally, but across the nation. That psychiatry is really, we don't have enough providers to fill the roles we have. We are stretching our med management services through using lots of mid-level providers, ARNPs, PAs, clinical pharmacists, and really leveraging those to create extensions to be able to do med management. I know that there are many primary care doctors that may be open to doing medications at least when they're not too complex of a case. I know we do some consultation with primary care office as well. Telepsych is certainly an option in Washington State. There are lots of different waivers in place right now that allow us to provide both video connections as well as audio only for the time being. And so one of the things that we've gotten creative with is using our providers wherever we need them. That the telehealth option really has, if we've got a shortage of some provider in Walla Walla, we can beam one of our Yakima folks down there or vice versa. And so I think there's organizations all across the state right now that are trying to figure out how do we provide good behavioral health care, including med management in rural, underserved areas. And that's going to be a continued conversation. I know there's lots of work going on right now around broadband access as well, because that's a struggle we have, that you may not even have access to telehealth in some portions, rural portions of Washington State, because of lack of broadband access. And how do we push that technology out to get people more access as well?
Great. Thank you. I think you answered two questions there, so very good. And we have a question here that sort of a follow-on. Are there telepsychiatric resources that you can share with us, or if not now, then perhaps later?
Yeah, not off the top of my head, but I'll do a little poking around and I can send what I can find in. I know the University of Washington is doing some outreach as well, and they're doing some training and support, again, to promote, develop the capacity of primary care providers in their communities to take on maybe some more challenging clients through some consultation and support.
Very good. Okay. That was another question from Brian Guan. Any other questions that people have they just like to articulate with their own voice, as opposed to typing something into the chat box? For Paul? Okay. Anybody on the Greater Columbia staff have questions for Paul, how what he's suggesting might fit into what the ACH is doing?
The other thing I'll do when we have our calendar of mental health first aid classes built out, we're going to try to do at least a couple a month. We'll get that turned in so you can get that out to the participants as well.
Great. Yeah. And your presentation will be posted to the Greater Columbia website here shortly, I'm sure. Okay.
Patrick, this is Carol. I just wanted to thank Paul for his presentation. I know it is on our radar screen about having more mental health first aid or youth mental health first aid classes available to our community, especially during this time. We think it'd be really valuable to have this information at our fingertips, be able to apply it within our workplace. So I'm glad to hear that they're going to be offering more of these classes, and I know that there are other organizations that offer them. So we are trying to work up some opportunities, and glad to know that Comprehensive has this available for us.
And if anyone thinks of a question afterwards, they can certainly send it to me afterwards. My email address is paul.nagelmcnaughton@comphc.org. I'll put that in the chat box, and they can email me directly if a question comes up.
That'd be great. Yeah. Thank you. Okay. Are there any other just questions of a general nature from the folks who are on the line that you'd like to pose to Paul, you'd like to pose to Cody, you'd like to pose to the Department of Health, or you'd like to pose to the Greater Columbia ACH? All right. Well, Paul and Cody, if you're still on the line, again, on behalf of the Greater Columbia ACH, I'd like to say thank you again for your efforts in putting together your presentations. Thank you for the very compelling presentations. And I think we will all walk away from the meeting today feeling a little bit better about our ability to cope with what's going on, and certainly better that we know that there's perhaps more resources out there than we knew of when we started the morning. So I'm gonna ask Wes or Diane to just tell the group what's coming up in the October Leadership Council meeting. Would one of you run to the mic to tell the group? Wes, Diane? All right, then the ball, yes.
I would be happy to review that. It sounds like Diane just got on.
Diane, are you there? Then why don't you go ahead and review, Carol?
Okay. Oh, Wes just said his microphone's not working. So October last year, you might recall that we had some wonderful presentations by our local health improvement networks about what they had been up to, and then also just some preliminary reports about what they were doing with the social determinants of health funding that they received from Greater Columbia ACH. This year, we'll have more of a report of how those funds were being utilized, and we're excited to repeat what we did last year with local health improvement networks reporting out on their activities for about 20 minutes, and then followed by a discussion with the third-party administrators of what they are doing with the funding that they received. So it should be a really interesting session, hearing back from our LINs and our third-party administrators in terms of how the social determinants of health funding has helped. And just to let everybody know, as GCACH contemplates its budget for 2021, I guess we're really looking for evidence that this was a good idea. And so I think it would really influence our ability to budget for another round of social determinants of health funding, depending on the results of those reports.
Okay. Thank you, Carol. So that will be in about a month. Yep. And as you see there, October 15th, actually a little less than a month at this point. As the person who facilitated that meeting last year, I have to say that was an excellent session, even with the challenge of trying to get all of the LINs to have their fair share of airtime. All right, well, with that, I again want to thank you all for coming today, and we hope this is of value, has been of value to your professional lives, to your personal lives, and we look forward to seeing you, so to speak, on October 15th at 9 o'clock.
Thank you, Patrick.
For now, unless Carol, you have any last minute things you'd like to say.
I do not. I just wanted to thank you and thank everybody for attending.
All right. With that, Chelsea, I think we're done.
Thanks, everybody.
Thank you.